Assalamu alaikum students. In your previous class you have studied the gross anatomy of bony orbit and one of its main contents, the eyeball. But eyeball occupies only 1/5 of the bony orbit, and orbit also contains accessory visual structures which are called adnexa oculi. Today we will discuss the connective tissue structures related to eyeball, extraocular muscles and movements of the eyeball. Number 1, orbital connective tissue and fat. The bony orbit contains a complex arrangement of connective tissue. This connective tissue not only forms supporting framework for the eyeball, but it also influences the movement of the eyeball. This connective tissue is arranged in various forms, like number 1, orbital septum. The orbital septum is a weak membranous sheath which is attached to the margins of the bony orbit, and here it becomes continuous with periosteum of the surrounding bones. This orbital septum extends into each eyelid and blends with tarsal plates, while in the upper eyelid it also blends with superficial lamella of Levator, palpebrae, superioris. In this diagram we can see the orbital septum which is attached to the margins of the bony orbit and extends into each eyelid. And in this diagram you can see this is orbital septum which is attached to the margin of the orbit and extend into each eyelid. These are tarsal plates. This orbital septum is not only fused with the tarsal plates but in the upper eyelid with a muscle that is called Levator palpebrae superioris. The cutaneous nerves and vessels which supplying the nearby areas like face and scalp, they have to pierce this orbital septum to reach their area, like supraorbital nerve and supratrochlear nerve and infratrochlear nerves. These pierce the orbital membrane. Next is fascial sheath of the eyeball which surrounds the eyeball. It is called bulbar fascia or tendinous capsule. It is loose membranous sheath around the eyeball. It extends anteriorly from the corneoscleral junction to the point where optic nerve enters the eyeball posteriorly. It is separated from the sclera by a space that is called episcleral space and only loosely attached to sclera by delicate bands of connective tissue. This sheath is attached strongly only at two sides, anteriorly at the to the limbus and posteriorly where the optic nerve enters the eyeball. Now this is fascial sheath, this in white color, attached only loosely and separated by episcleral space and reflects onto muscles. This is fascial sheath. The ciliary nerves and vessels pierce this sheath to enter the eyeball. Similarly, all the extraocular muscles perforate the sheath to get attached on the sclera. This sheath provides a socket for the eyeball and support it. The fascial sheath not only surrounds the eyeball but it reflects at the corneoscleral junction over the muscles. So it also forms tubular sheath for the muscles. These in blue line, these are tubular sheaths for the extraocular muscles. Then medial and lateral check ligaments. These are strong triangular expansions. These strong triangular expansions from the sheaths of medial and lateral recti. On the medial side they are attached to lacrimal bone, while on the lateral side they are attached to zygomatic tubercle of the zygomatic bone. These are called check ligaments because they limit the movements of medial and lateral recti muscles. Suspensory ligament of lockwood. Suspensory ligament of eye. The sheath of inferior rectus is thickened on its underside and it blends with the sheath of inferior oblique muscles. These are cut sections of the muscles, extraocular muscles. Sheath of inferior rectus muscle blends with sheath of inferior oblique muscles, and then these sheaths on each side become continuous with the sheaths of medial and lateral rectus muscle. In this way it forms a continuous band, this fascial band. This fascial band is called suspensory ligament of the eye. You can see these are check ligaments on each side. These are the sheaths which surround lateral and medial rectus muscle, and how they become continuous with the fascial sheaths of inferior rectus and inferior oblique muscle. Now this sheath suspends like a hammock below the eye, and it provides strong support for the eyeball. And even if the maxilla is fractured, which form a floor of the orbit, or maxilla is removed, even then the eyeball can maintain its position. Now have you noticed that when our gaze is directed superiorly, the superior eyelid also elevates, and when we look downward, inferior eyelid retracts. This is also due to this facial expansions. The muscle sheath of levator and superior rectus are fused, right? And levator, palpebrae, superioris will extend into upper eyelid. So when the gaze is directed superiorly, the superior eyelid also elevates. And similar expansion of facial sheath of inferior rectus extends into lower eyelid. It is also called inferior check ligament, and this expansion retracts the inferior eyelid when the gaze is directed downward. The next is orbital fascia or periorbita. It is simply periosteum which covers the inner aspect of the bony orbit, and it is called periorbita or orbital fascia. Then after the connective tissue we have orbital fat. Now the spaces between the main structures of the orbit, these are occupied by fat, particularly in the region between the optic nerve and the surrounding cone of muscle. But this fat is also present between the muscles and periosteum of the orbit, and it is limited anteriorly by the orbital septum. This fat helps to stabilize the position of eyeball. It also acts as a socket within which the eye can rotate. In this diagram we can see the fat which is present between the cone of muscles. These are extraocular muscle, and this is eyeball, and this is optic nerve, and remaining space you can see this is filled with fat, and it provides a matrix for the nerve and vessels of the eyeball. It not only supports the structures but also acts as a socket. The conditions resulting in an increased overall volume of the orbital fat, and there may be swelling of extraocular muscles like in hyperthyroidism, the condition which is called Graves' disease. It may lead to forward protrusion of the eyeball, that is called exophthalmos. In reverse, any disease or in starvation which reduce the retrobulbar fat, the eyeball is retracted into orbit. The condition is called enophthalmos. Now we will start the extraocular muscles, but before going to muscles, I want to discuss common tendinous ring. Common tendinous ring is also called common annular ring or tendinous ring of Zinn. It is a fibrous ring. This fibrous ring which is attached posteriorly near the apex of the orbit on its inner aspect, and it surrounds the optic canal and part of superior orbital fissure. Actually, this fibrous ring divides the superior orbital fissure into three parts: lateral part, central part, and medial part. Now we can see the structures passing through superior orbital fissure within this tendinous ring of Zinn. These are nasociliary nerve with upper and lower divisions of oculomotor nerve and the sixth or abducent nerve, while optic nerve with ophthalmic artery also pass through this tendinous ring but outside the superior orbital fissure. This tendinous ring give origin to all the four recti muscles: the superior and inferior, medial and lateral rectus muscles of the eye take origin from this tendinous ring. Now, extraocular muscles. Extraocular muscles or extrinsic muscles can be divided into two main groups: voluntary or skeletal muscles and involuntary smooth muscles. Voluntary muscles include four recti: the superior, inferior, medial, and lateral; two oblique, the superior and inferior; and levator, palpebrae, superioris. While involuntary muscles consist of superior and inferior tarsal muscle and a small orbitalis muscle. First of all, voluntary or skeletal muscles. Number one is the superior rectus. You must know the origin, insertion, and action of each of the muscles. Superior rectus muscle takes origin from the upper part of tendinous ring, but some fibers also arise from the dural sheath of the optic nerve. This is superior rectus muscle. Its insertion is on the sclera 8 mm behind the limbus, and the action of muscles we will discuss with the movements of the muscle. Inferior rectus muscle, it takes origin again from the common tendinous ring, and insertion is on the sclera below the cornea, approximately 6.5 mm behind the limbus. Its main action is depression of the eyeball, but it also causes adduction and lateral rotation of the eyeball. Medial rectus. Medial rectus muscle takes origin from the common tendinous ring and inserted into medial surface of the sclera, approximately 5 mm behind the limbus. Medial rectus moves the eye, so it is directed medially. Movement is called adduction. Lateral rectus. Lateral rectus muscle also takes origin from the common tendinous ring. Some fibers also arise from greater wing of sphenoid. Its insertion on the lateral surface of the sclera, about 7 mm from the limbus. Lateral rectus moves the eye so that it is directed laterally, that is called abducted eye. So all the four recti have a common origin from the common tendinous ring, and they all are inserted on the sclera behind the limbus in superior, inferior, medial and lateral aspects of the sclera. The next two are oblique muscles. The first is superior oblique muscle. Superior oblique muscle is a fusiform muscle that arises from body of sphenoid supromedial to optic canal. It runs forward and ends in a round tendon. See, this round tendon passes through trochlea, a fibrocartilaginous loop which is attached in the trochlear fossa on medial aspect, medial wall of the eye. From here it changes its direction and runs in posterolateral direction, and ultimately it attaches to the sclera in the superolateral part of posterior quadrant behind the equator. Now this is the line which divides the eyeball into interior and posterior halves. This line is called equator, and these are lateral quadrants, anterior and posterior. So this is posterior quadrant, and its upper part gives attachment to superior oblique muscle. Superior oblique muscle is inserted into posterior part of the eyeball. So when it contracts, the back of the eyeball is elevated. We will discuss this action in detail with the movements of the eyeball. So when the back of the eyeball is elevated, the front of the eyeball is depressed. So it causes depression of the eyeball. But superior oblique also moves the eye laterally and also do intorsion of the eyeball. Inferior oblique. Inferior oblique muscle, this is the only muscle which takes origin from anterior aspect of the orbit. It arises from the orbital surface of the maxilla lateral to the nasolacrimal fossa, right? It ascends posterolaterally below the eyeball, at first between the inferior rectus and orbital floor, and then between the eyeball and lateral rectus, and ultimately it reaches the posterolateral quadrant of the eyeball, where is inserted into lateral part of the sclera. Now as inferior oblique muscle is inserted into posterior part of the eyeball in the same quadrant, when the inferior oblique muscle contracts, the back of the eyeball is depressed. So when back of the eyeball is depressed, the front of the eyeball is elevated. So it causes elevation of the eyeball, but inferior oblique muscle also causes abduction and extorsion of the eyeball. We will discuss with the movements of eyeball. Levator palpebrae superioris. This muscle takes origin from the inferior aspect of lesser wing of sphenoid, above and anterior to optic canal. This muscle has two lamellae. The superior lamellae ends in front in a wide aponeurosis. Some of its tendinous fibers pass straight into upper eyelid and attach to superior tarsal plate, while the rest radiate and pierce the orbicularis oculi to pass to the skin of the upper eyelid. Now in this diagram you can see how the levator palpebrae superioris change into aponeurosis and get attached on the superior tarsal plate, while inferior lamella which extends from it and it attached to upper margin of the superior tarsus, and this is also called superior tarsal muscle of muller, and actually it is not a skeletal muscle but it consists of smooth muscle fibers. आईबॉल की मूवमेंट्स को पढ़ने से पहले कुछ एक्सेस को अंडरस्टैंड करना ज़रूरी है. Each orbital cavity is pyramidal in shape with its apex directed posteromedially while the base is directed anterolaterally. Now if we draw an imaginary line from which passes through center of this quadrangular margin, this line is called axis of the orbit, and the second line which passes anteroposteriorly from the center of pupil, this axis is called optical axis or axis of gaze. And now you can see the both axes do not coincide with each other, and orbital axes diverge for about 23 degree from the anteroposterior axis or axis of a gaze, and this difference of angle influence the movements of eyeball and action of different extraocular muscles. There are three axes for the movement of eyeball, and all the movements of eyeball are rotatory movements around these three axes. These axes are vertical axis, this one is transverse or horizontal axis, and this is anteroposterior axis which passes through center of the pupil. And all the axes pass through the equator, which divide the eyeball into anterior and posterior parts. Now each axis with two movements. Number one, vertical axis. On the vertical axis there are two movements of the eyeball. One is adduction and the other is abduction. Adduction, when the eyeball rotates medially, and maximum limit is 50 degrees, and abduction, when the eyeball rotate laterally. Both these movements occur on vertical axis. In adduction, the main muscle is medial rectus muscle, while the superior rectus and inferior rectus, they act as synadistic muscles. They are collectively called as medial rotators or convergents of the eyeball. Abduction, main muscle is lateral rectus, assisted by superior oblique and inferior oblique muscles. They are also called lateral rotator or divergence of the eyeball. जब भी मूवमेंट्स को डिस्क्राइब करेंगे आई बॉल पर, तो ये एनाटॉमिकल पोजीशन में प्राइमरी पोजीशन में डिस्क्राइब होंगी व्हेन द आईज आर लुकिंग स्ट्रेट अहेड. ठीक है, दिस इज प्राइमरी पोजीशन ऑफ द आई बॉल, और उससे मूवमेंट्स को डिस्क्राइब करेंगे. नाउ दिस इज प्राइमरी पोजीशन, एंड इन दिस डायग्राम इन द राइट आई दिस इज एडक्शन. ठीक है, बाय द मीडियल रेक्टस मसल, while on the left eye this is abduction by the lateral rectus muscle. The same movements in the opposite eyes, and these are the muscles, and these movements occur on the vertical axis. And in this is lateral rectus muscle, and this one is medial rectus muscle, and this is the direction of contraction of the muscles. So when these muscles contract on vertical axis, they cause adduction and abduction of the eyeball. The next axis is horizontal or transverse axis, and the movements which occur on this axis are elevation and depression. In elevation, eyeball rotates upwards. This is primarily brought about by superior rectus muscle and assisted by inferior oblique muscle. While depression, when the eyeball rotates downwards, and the primary muscle in this is inferior rectus assisted by superior oblique muscle. Now in this diagram we can see the muscles which cause elevation and depression. ये तो सिंपल हो गया. दिस इज सुपीरियर रेक्टस मसल. जब ये कॉन्ट्रैक्ट करेगा इट विल सिंपली एलिवेट द आई बॉल अपवर्ड, दैट इज कॉल्ड एलिवेशन. बट हाउ inferior oblique muscle cause elevation? This is the only muscle which arises from anterior aspect of the orbit, passes below the eyeball, and it is attached to posterolateral quadrant. तो actually जो इसका action है वो posterior part of eyeball पे होगा, and when it contracts it depresses the posterior part of the eyeball. So automatically anterior part of the eyeball will elevate. तो इस तरह से inferior oblique causes elevation of the eyeball. Similarly, inferior rectus muscle on this horizontal axis cause depression of the eyeball. Simply जब ये contract करेगा तो eyeball will rotate downwards. But how the superior oblique will cause depression? Superior oblique arises posteriorly. Anteriorly it passes through pulley which change its direction of pull. It also attached to posterolateral quadrant of the eyeball. So its action also on the posterior part of the eyeball. When it contract, it will elevate posterior part of the eyeball. तो जब posterior part of eyeball elevate होगा तो anterior part of eyeball depress हो जाएगा. इस तरह से inferior oblique muscle elevation करता है जबकि superior oblique muscle depression करता है in the primary position. अब आप देखो ये प्राइमरी पोजीशन है आईबॉल की, ठीक है. इस प्राइमरी पोजीशन से जब एलिवेशन होगी तो इट विल बी डन बोथ बाय सुपीरियर रेक्टस एंड इंफीरियर ओब्लिक मसल. और किस तरह से ये अभी हमने डिस्कस किया. सिमिलरली दिस इज डिप्रेशन ऑफ द आईबॉल एंड मसल्स आर सुपीरियर ओब्लिक एंड इंफीरियर रेक्टस मसल. Next axis is anteroposterior axis, and again two movements on this axis. One is intorsion and the other is extorsion, which is a reversal of intorsion. So rotation of eyeball on anteroposterior axis, in which midpoint of upper rim of cornea, which is often referred to as 12 o'clock position, is rotated medially. This is definition of intorsion. इसमें क्या है कि कॉर्निया का जो आउटर रिम है उसका मिड पॉइंट लेना है और उस रेफरेंस लेते हैं हम 12 o'clock पोजीशन का. अगर वो एंट्रोपोस्टीरियर एक्सिस पे 12 o'clock पोजीशन से मीडियली रोटेट करे तो दिस मूवमेंट इज कॉल्ड इंटॉर्शन. और इसका रिवर्स है एक्सटॉर्जन, जिसमें है रोटेशन ऑफ eyeball on AP axis when corneal 12 o'clock position turns laterally. Now the muscles which are involved in intorsion are superior rectus and superior oblique muscle, while extorsion inferior rectus and inferior oblique muscles. Now this is outer rim of the cornea and this is 12 o'clock position. So medial rotation on anteroposterior axis. When the eyeball rotates medially, this is called intorsion. This is direction of movement, intorsion. And intorsion is brought about by superior oblique muscle and superior rectus muscle. As it passes through pulley, its line of pull changes and it rotates the eyeball medially on anteroposterior axis. Axis देखें चेंज हो गया. यहाँ पर भी ये superior oblique इसको medially rotate कर रहा है, जबकि superior rectus muscle जो कि posteriorly apex पे अटैच है tendinous रंग से, तो इसका भी लाइन ऑफ पुल मीडियल है क्योंकि एपेक्स पोस्टीरियरली मीडियली डायरेक्टेड है वाइल बेस इज डायरेक्टेड लैटरली. तो ये दो मसल्स हैं जो इंटॉर्जन करेंगे और इसका रिवर्सल एक्सटॉर्जन है. एंड एक्सटॉर्जन इज ब्रॉट अबाउट बाय इंफीरियर ओब्लिक मसल एंड इंफीरियर रेक्टस मसल. So the summary of movements in this superior rectus, inferior rectus with medial rectus cause adduction, lateral rectus with inferior oblique and superior oblique muscles cause abduction, superior rectus and inferior oblique cause elevation of the eyeball, while superior oblique and inferior rectus cause depression of the eyeball. We will discuss the nerve supply and clinical correlates in our next class, and in the video class we will discuss the movements of the eyeball again. Thank you so much.